Good afternoon, everyone, and welcome to the 2020 series of free webinars sponsored by the Canadian Association for Suicide Prevention, the Quebec Association for Suicide Prevention, and the Centre for Research and Intervention on Suicide, Ethical Issues, and End-of-Life Practices at the Université du Québec à Montréal. These days were initially planned for the National Conference on Suicide Prevention to be held at the Université du Québec à Montréal in Montreal, Quebec. However, because of COVID, that event has been rescheduled for October 27 to the 29th, 2021 in Montreal, with free conference activities being held on the 26th of October 2021. Please mark those dates in your calendar and check out the website of CASP, AQPS, or CRISE for further information about this major national event. Hi, everyone, again. My name is Lorraine Millette, Project Coordinator and Research Agent for the CRISE. Today, I have the pleasure of introducing Dr. Brian Greenfield, an Associate Professor of Psychiatry and Paediatrics at McGill University, Faculty of Medicine. Dr. Greenfield is also the Director of Montreal Children's Hospital Mental Health Emergency Team. He will be speaking for about 40 minutes, and then we will have a 20-minute question period. If you have any questions during the presentation, please write them in the Q&A, or for the ones who have a French keyboard, the Q&R, which can be found at the bottom of your screen. It will not be possible for Dr. Greenfield to directly read the questions, so I'll be monitoring I will be monitoring the questions and reading them at the end of his presentation. Total time of the presentation and question period will be 1 hour, and we should finish no later than 5 minutes after the hour. Please keep in mind, though, that all presentations are being recorded and you'll be able to access them in a few weeks from now on the websites of the three organizers, CASP, AQPS, and CRISE. With no further ado, I now invite Dr. Greenfield to begin the webinar.
Hello, everybody. We're going to share the screen with you now. Are we going to share? Oh, it's beautiful. Thank you for having me here today. Thank you to the CRISE and the two other organizations. It's going to be a pleasure for me to discuss this issue of reconsidering the adolescent borderline personality disorder construct based on the follow-up of 286 previously suicidal adolescents. I'm thanking the Hogg Family Foundation and the Montreal Children's Hospital Foundation that have made funding in the past available to me. And I want to thank my co-investigators, Ashley Wazana, whose lab I'm working with now in conjunction with Alexia Jolicoeur-Martineau, the statistician, Maria Brown, who's been great in making references for a submission that we're gonna put in next Tuesday. For a journal named Preventive Medicine. This is a solicited article, which is quite exciting. Bonnie Harnden, who worked with me in research and on my clinical team, Shamila Ahmadi and Tanya Viviani, who have been project coordinators with me for a number of years now and has helped formulate my thoughts and feelings about this subject. And Brian Tran, his name is written wrong there, Tanya Sassoon, Levan Boudagian, who were students who work with me on this. So this is a concept in evolution. Every day, including this morning, I think about it and I'm resculpting and restructuring my thoughts on BPD, borderline personality disorder. Just a bit of background. Suicide is the second cause of death in the ages 10 to 24 in the US. The rate is 9.75 per 100,000 population, 15 to 19-year-olds. And I was fortunate enough to be co-author, one of three, in an article that came out in JAMA in 2019, which demonstrated that the admission rate of youth with suicide ideation, suicide attempts to the United States emergency rooms, approximately a 10-year period had actually doubled. And Brett Burstein was the first author. And for me, that was actually exciting because it told me that schools were getting healthier now, that the stigma has decreased, and professors, teachers, and school administrators are now signaling youth at risk and sending them to the emergency room. There was a variable interpretation that actually, no, this is a bad sign because the kids are actually killing themselves. And so Dr. Brian Mishara, who lectured before, actually had an article in the same journal, JAMA, and I think it was in 2019 or beginning of 2020, which actually demonstrated an increased rate in the youth population of suicides. As you know, suicide in early childhood predicts suicide ideation in later childhood and ideation and attempts in adulthood. So get in early, make it better. They're at less risk later on of committing suicide. 46% of those in the 10 to 17-year-old age group who complete suicide are diagnosed with a mental health problem. Only 30% have been treated, and I'm going to talk about that today. And I'm hoping to move forward. Yeah, 10% of those with BPD suicide by age 30. That's a very important number because I'm underlining that because if we can do something for this population now, we can lower the suicide rate. And I hope you can have a better idea of that in about 35 minutes. BPD is prevalent in 1 to 6% of the general population. And I wrote here 10 to 15% of psychiatric samples. I actually think it's higher than that. Adversity is very common in this population, and I first started reading that decades ago from Joel Paris, where he talked about sexual abuse in this population. Excuse me, I'm just gonna hydrate. The treatments for borderline personality that meet with modest success include the therapeutic treatment of dialectic behavior therapy. I've been very impressed with youth that have been through trials of DBT. I see them occasionally in the emergency room, and indeed they've learned a lot, and that's reassuring. Pharmacologic is symptom management if they come in anxious, depressed, or if they even have delusions or hallucinations. And I may get a chance to talk more about that today. So the big question today is BPD a homogeneous disorder, or is it an amalgam of several different disorders? And I hope to convince you that is potentially an amalgam. So in around 2015, in the European Journal of Child and Adolescent Psychiatry, I was first author on a publication which described the correlates, predictors, and stability of BPD. And I was so excited by that. I wanted to impress the research world that indeed there was data available to consolidate this diagnosis, this construct in the adolescent population. And in the correlates, we see drug use clearly differentiated the borderlines from the non-borderlines presenting suicidal for the first time in adolescence to an emergency room. Family conflict was greater than non-borderlines. Conduct disorder, higher prevalence. The borderlines were different from non-borderlines by virtue of greater stressors by the Coddington Life Events Scale, and poorer functioning on the basis of the Children's Global Assessment Scale. Drug use was that was an unstructured measure we used. Family conflict was the index of family relations. Conduct disorder was driven by the DISC, the Diagnostic Interview Schedule for Children. The predictors were those who were greater than 14 at their first presentation, and those who had poorer functioning, borderline versus non-borderline, at recruitment. Age greater than 14 years old, I understood that as it took too long for them to come in. By that time, their primitive defenses had been consolidated, and it was just harder for them to untangle their borderline pathology so that we would see it age greater than 14 as a predictor of borderline pathology 4 years later. And this, by the way, was a study done in the late 90s, early 2000. And I'll just give you a very brief overview of that. When I came onto the team in 1987, Dr. Gabby Weiss, who was my chief at the time, asked me to head up a follow-up team to make sure that kids coming into the emergency room would not fall through the cracks. And I was able to demonstrate that by virtue of the introduction of our follow-up team, the hospitalization rate plummeted. It went from approximately 21% down to 14%. So with Dr. Lily Heckman, we asked the question, well, it's all well and good that the hospitalization rate is down with this rapid onset follow-up team outpatient, but are the kids killing themselves? That would certainly not be a good outcome. So we conducted a randomized controlled trial, and without getting into the nitty-gritty of it, I'll just say that one team had access to the rapid onset, rapidly responsive outpatient model, and the other team did not. And so there was a difference in the hospitalization rates. The team that had access to the outpatient model had a 17% hospitalization rate, and the team that did not have access to the outpatient model had a 42% hospitalization rate. So a huge discrepancy in hospitalization rates. And I've lectured on this to the CRISE before. The outcome of these youth was approximately the same based on functioning and suicidality 6 months later, which was outstanding. And it was in that study I realized that I had data on borderline pathology for this group, and that is driving this presentation today. The stability of this diagnostic construct from recruitment. I meet criteria for borderline pathology at time 1, and I also meet criteria for borderline pathology 4 years later, time 4, was very high. It was over 70%, in fact, into the low 80s. What was also striking about the suicidality of the kids is that it plummeted 2 months after admission to the emergency room. A lot of the kids were no longer suicidal. In fact, 92% were no longer suicidal. And of the 8% that were still suicidal at 4-year follow-up, 100% had borderline pathology. So this phenomenon of suicidality responds either to interventions in the emergency room or through a natural setting. So a lot of these kids get better, 92% get better. And of the 8%, they still meet criteria of borderline pathology. So with Ashley and Alexia and Maria, we looked at further criteria of validity, and we said, I already demonstrated that there are predictors of outcome, there are correlates at recruitment, it is a stable phenomenon, but does it impact other disorders? Let's take a look. I'm going to hydrate a bit more. I'm going to take you on a little historical background of BPD. As you know, Kernberg in 1975 talked about the primitive defenses. And as you know, defense mechanisms they're rooted in our ego, and they help us deal with moderating between our aggressive and sexual drives and the constraints of society. The really primitive defenses, you know, are denial and projection. Denial, we're already upon winter here in Canada. And if I went out in my bathing suit pretending it's summertime, that's a form of denial. Projection is putting any unwanted affect, conflict, or thought, trying to put that outside into someone else. Simple projection, you won't take it, it's psychotic. It's a primitive defense. The mature ones are altruism and sense of humor, for example. In between the mature defenses and the primitive psychotic ones are the borderline defenses. And we go through them. Everyone goes through them during development. They include you're all good, idealization, you're all bad, devaluation. Those on the left side of the room are good, on the right side are bad, splitting. And projective identification, again, I'm trying to get rid of unwanted feelings, thoughts, or conflicts. I will try to put them into you, and you will identify with them. And that's called projective identification. And in the therapy process, we try to exchange the primitive defenses, the projective defenses, for more mature ones. Gunderson and Singer talked about the borderlines having intense affects, many psychotic episodes, impulsive behavior, I'm not so sure, loose thinking and unstructured situations. If we have time, we'll talk about that, and alternating between superficial relationships and intense dependency. Now, Masterson came along and talked about abandonment depression in this population, where they sabotage separation, individuation. And that's also a very useful concept, because that tells us that there's something in the dynamic between the family and the child that wants to keep the child young and not mature, not adopting more mature defenses. And that can be accomplished very well if the parent-child don't separate and if they stay in a primitive relationship, according to Margaret Mahler. But it would take another presentation to talk about that. But I would encourage you to read on Margaret Mahler and also to read up on Masterson. The DSM talked about BPD as having 4 critical components: the interpersonal difficulties, impulsivity, let's talk about that, affective dysregulation, and cognitive issues. The interpersonal conflicts were put on the wayside because it was felt about 10 to 15 years ago that that was too nonspecific, and that was shared by other personality disorders. So we were left with impulsivity, affective dysregulation, and cognitions, which is all well and good, except that I'm going to describe something about impulsivity that may compel you to think twice about. Sorry, I'm not getting that button. Linehan came along from my alma mater, University of Washington, and she said, there's a lack of attunement between the parent and the child. When I heard that, I thought, interesting. And it corresponds a bit to what Joel Paris was detecting as adversity in the background of these youth. And by the way, this lecture is, I can only claim validity with respect to our findings in the adolescent population. So I'm inviting you all to think about this and research it in the adult side. Now, I like Linehan. As I get older, I really like Linehan's concept of the lack of attunement, and we'll come back to that really soon. Eric Liss and I wrote an article covering the genetics and the neuroimaging of borderline pathology in youth. And one of the things that sprang forward was the irregularities of the dinosaur in our brains, the limbic lobe, and the irregularities in the frontal lobes of our brains. And that's really interesting because it talks to impulsivity, and there's a confluence between the two in a very pretty way. And what we found was that in our literature reviews, that the limbic lobe, surprisingly to me, was found to be smaller in these youth, but hyper-functioning. And so that could give us some idea about the impulsivity, irritability, and affective dysregulation. And if there's not a strong link between the frontal lobe, the executive function controlling the dinosaur, or the horseback rider controlling the horse, then we got a problem when the horse or the dinosaur gets angry and irritable. Gustavo Turecki, my current chair, in 1999, very cleverly found in postmortem brains that there were irregularities in the serotonergic receptors, specifically around irritability. And he's written more recently about irritability, very fine summaries, and I encourage you to read them. That takes us to ACE, and I'm just going to see where I'm at in the presentation so I can better have a sense, because they're not numbered on the screen. Okay, they're not numbered in my papers either. I'm at 227. So let me separate myself from BPD for a moment and tell you a story about adversity. A lot of the kids, and I haven't published this yet, but probably 90% of the kids I see in the emergency room that are adolescent suicidal kids have ACE in their background. ACE broadly define adversity, adverse childhood events, as separation, divorce, child physical abuse, sexual abuse, emotional abuse, a lot of that out there. Parents in prison, parents hospitalized, parents separated from children on the basis of famine or war, just to name a few. So my team at CLSC Verdun has turned me on to the concept of ACE over the last couple of years. And I'm quite struck that the concept of chronic, complex post-traumatic stress disorder is so prevalent in this population I see in the emergency room. Well, what is PTSD? Well, defined by the World Health Organization, 2018, these youth will re-experience their traumatic event. It's very real. They avoid traumatic reminders, so any opportunity where they think that there'll be some recollection of the event or something will resonate in their current life with the events of the past, they'll avoid it, and a sense of perceived and current threat. Their galvanic skin response is high. Well, what about complex post-traumatic stress disorder? You take the PTSD, into that you add interpersonal problems, negative self-concept, interpersonal sensitivity, and affect dysregulation. And I'm thinking, oh, that looks a little bit like my friend's BPD, the adolescent BPD group. And so I'm wondering, how can I differentiate between these guys with CPTSD and my friends, the adolescent BPD? So in the literature, they talk about BPD endorsing these above criteria more than CPTSD. I'm not so sure, because how do you differentiate between participants who have CPTSD and participants who have BPD? And if it's hard to differentiate between the two, how can you find that some endorse more criteria than the other? Again, BPD, 50% are suicidal, but only 14% of CPTSD and 17% of PTSD are suicidal. Again, I'm skeptical. Let's go on. Let's look at the impulsive part of BPD. And I'm at, let's go. Come on, baby. 230. Good. Making good progress. Carlson turned child psychiatry a bit upside down, Gabrielle Carlson, by looking at impulsivity and irritability in the early 2000s and saying, this is pediatric bipolar disorder. And the diagnostic incidence of pediatric bipolarity shot up. And I think ultimately within a year, there were 500% more diagnoses of pediatric bipolar disorder than previously. In the paper that Eric Liss and I wrote in 2007, we talked about the need for irritability endophenotypes. In other words, irritability maybe it confused those who were calling it pediatric bipolar disorder because it was a component of manic depressive illness in adults. It was considered a critical component of BPD. Maybe people who were depressed were also irritable. So Eric and I said, you know what, let's call it an endo, meaning genetically driven endophenotype expressed as irritability. And let's start with that endophenotype and look at the individuals more closely who possess it or demonstrate it. And let's start from that as an anchor to determine who then goes on to BPD, bipolarity. NIMH, 3 years later, started what were called the research domain criteria, the RDocs of irritability in the endophenotypes. Liebenloft, approximately 1 year later, came out with irritability criteria under the rubric of severe mood disorder. And there were a certain number of times per week that one could be irritable to achieve that diagnosis. Axelson in 2013 coined the term disruptive mood dysregulation disorder. And I believe the criteria for that were irritability at least 3 times a week. So can you really differentiate an irritability that's 2.5 times a week versus 3.01 times per week? I'm not at all clear on that. And by the way, before this all was moving around, we had the explosive personality disorder. And how do you differentiate between explosive personality disorder and the impulsivity of ADHD? This is all a very fuzzy boundary. So what hypotheses did myself, Ashley, Alexia, Maria have in reviewing our 286 kids longitudinally, looking at BPD specifically? We said, I was convinced that BPD was going to have an impact on the persistence of other disorders associated with suicide, conduct disorder, depression, suicidality, and poor functioning. I was excited that we were going to find evidence of the sex-based bifurcation that was found in the adulthood in adolescence. Very excited by that. I was perceiving that treatment was going to lead to a non-persistence of BPD. It stands to reason if this is a disorder, you treat it, it gets better. That DYP was going to predict persisting BPD, and that was driven more by clinical experience where I kept seeing these kids bouncing back from youth protection that had been placed at a group home. I felt that we would take a more thorough look at BPD and find that the stability was going to persist, and that once again, the predictors of follow-up would be at age greater than 14 years old. I started approximately at 2:10, and it's now 25 minutes later. I have 15 minutes to go, so I'm going to move fast through this slide, and I'm going to say that we called these kids back. Remember, I did a study of who would do better, rapid response outpatient versus hospitalization, and we followed them for 6 months, no difference in the samples. For this study, we followed them 4 years later. The measures, I mentioned a few before. We had an abbreviated measure of diagnostic interview of borderlines with Jean-Marc Guillet and Jean-Jacques Breton at Rivière-des-Prairies were involved with, and Réal Labelle, I think, was involved in abbreviating the diagnostic interview of borderlines. That was subsequently translated into several languages, and that permitted us to talk about the correlates that I spoke of before, the correlates, predictors, and stability of the sample of BPD. Sample was kids that we came in consecutively suicidal to the emergency room of the Children's Hospital, and how do we manage them? Rapidly responsive outpatient, we gave them what they needed, which could have been couple, could have been individual work, social services, pharmacologic management. The same thing for those who are hospitalized. I wanted to overwhelm you with a table that had a lot of numbers on it that you couldn't possibly see. Column 1, they're not BPD amongst our 286. Column 2, they have BPD. Column 3, in a 1, 2, 3, 4, 5, in 6 of the categories out of about 20, there are no significant differences. Everywhere else, there are significant differences. Take my word for it. So one of them is drug use. One of them is youth protection, higher usage amongst those with BPD, family relations, messed up with the borderline kids, stressors, problematic with the borderlines, conduct disorder, higher, depression, higher, suicidality, higher, functioning, lower, and that's it. So these 2 columns tell us that amongst our population, the kids with BPD on univariate analysis are so different than the kids without BPD, and I celebrated because it confirmed my clinical experience. But we put it into a multivariate regression, and what we found was that, I'm going to move back, there was no impact of BPD on suicide. It evaporated in a multivariate analysis. There was no impact on functioning. It evaporated on multivariate analysis. None on depression or conduct disorder. BPD somehow became dissociated from these other variables and markers of distress. So my heart sank, and then I spoke about it with Ashley and Alexia and Maria, and we said, well, that's worthy of a paper. Let's talk about this follow-up sample and questioning the validity of BPD. So what are the results? One of the big results was that the last slide, BPD had no impact on these other outcomes. And I thought for sure, I'm a backpacker, and I love carrying a pack in the woods. It gets me out of my head, and I can breathe the fresh air. And I thought, you know, I once went many days in the backwoods with 42 pounds. And then the next year, without much training, I tried to go in with 50 pounds, and I struggled. And I thought BPD was a 50-pounder, and it was going to make the journey slower and harder, and it didn't. Second hypothesis, the age of sex-based bifurcation would be found in adolescence. It wasn't, and I'll have to talk about that with you in the discussion. Why not? There would be a treatment response, a differential, those who are hospitalized versus those with treated rapid response outpatient. I would love to play with you, if this were not in a webinar, to see who would thought that one treatment would be beneficial more so than the other. They were equal. So even for the vast majority of suicidal kids, the treatments are basically equivalent. And for the borderline kids specifically, outpatient management, rapid responsive versus hospitalization is pretty much equivalent. Did DYP have an impact on borderline pathology? They neither got better nor worse. And I think that has something to do with actually DYP prevented these kids from deteriorating further. I'm going to call the cup half full and give them the benefit of the doubt. I think they do good work, and they prevent the kids from slipping further down. It's highly stable, 82%, and the predictors of BPD at outcome for your follow-up are low functioning, higher age, but not suicidality. Suicide is not a predictor of BPD, and it's not a proxy of BPD. And I spoke about my data with Drew Weston about 15 years ago. And he was saying that very emphatically. And now I can say it emphatically, it's not. And it's really interesting that we've been conflating the two, and inappropriately. So this is another complex slide, and I'm going to make it really simple. The outcomes are on the right: suicide, depression, functioning, persisting depression, conduct, and BPD. The variables that could contribute to these outcomes on the right, I want to draw your attention to the third column from the left, where there's an arrow down and an FX, decreased functioning. How important decreased functioning is to predicting suicide later on, depression later on, poor functioning later on, conduct and BPD later on. So I'm underlining poor functioning. And the fourth column from the left, DYP, not BPD, is responsible for outcomes: suicide, depression, poor functioning, persisting depression. So where does poor functioning come from? And where does DYP, Department of Youth Protection, that's basically social services, where does that come from? Let's talk about it. We've already said BPD is stable, but no impact on other disorders. If it's not impacting these other variables, maybe it's a symptom and resulting from previous harm. If it's a disorder, it has to cause harm to the patient. But if it's not, we have to think of something else, maybe a symptom or a trait. There was no difference on multivariate analysis, BPD, non-BPD. That DYP and poor functioning, not BPD, predicted suicide, poor functioning, and depression. And that DYP and poor functioning are both adversity. And you'll hear me say that ad nauseum now. Suicide itself predicts very little. It's a broad marker of distress. And frankly, it was an entry criterion into the study. So I'm not sure that we can draw definitive conclusions with respect to suicide within the sample, but let's go on. There was no sex-based bifurcation. Now, I'm going to take a foray into the adult arena for a moment, and I'm going to say, I think the adult arena has a bifurcation because they underestimate BPD's prevalence amongst men. And I think the measures for BPD, and I need to speak with Jean-Marc Hillet and Réa Labelle and Jean-Jacques Berton about this, that I think we should have better measures of BPD for the male sex. I think also what's happening is that we've been conflating irritability and BPD. And I think a lot of the women who are irritable fall into the class of BPD, and they shouldn't. I think that should be reappropriated to ADHD-I, the impulsivity or irritability part of ADHD. And also, we all have primitive defense mechanisms when we're younger. Boys don't have any more than girls that I'm aware of in development. And if that's the case, then it stands to reason that there shouldn't be a bifurcation, that they should both grow up immature, and there should be equality between the sexes there. There was no treatment response on BPD, but I think if we separate the irritability part that's now conflated with BPD and call it ADHD-I, we can treat the irritability. We have treatment for it now. There's no impact, there's no salutary impact of DYP on BPD, but in fact, I think DYP prevents BPD getting worse. I'm gonna move on. BPD is stable. Adversity is the culprit. And so what is BPD? Let me tell you what I don't think it is. If you ask a kid, and if I were pointing with a pointer, on the left side is a weak subject. That means an academic subject. As soon as you hear a kid has weakness, like a learning disorder, bing, 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 think about ADHD-I when they come suicidal to the emergency room. Or if there's an argument between the child and the parent, bing, 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 think of irritability and the broad spectrum ADHD-I, oppositionality, learning disorders, tic disorders. So I don't think any of these belong to BPD, and I think you'll agree with me. Learning disorders, oppositionality, attention, activity, impulsivity or tantrums. Put it out of your mind now, and tics. If you assign it to ADHD-I, we can now treat the irritability, and we have alpha-2 agonists that do a good job with irritability. So what is BPD? I think it is adversity leading to weak boundaries, immature defenses, and ending up with the criteria essentially of the CPTSD, not necessarily the PTSD part, but why not? /BPD. And that consolidates Joe Paris's observations of decades ago that talk about adversity in the background of kids with BPD. But then what is BPD? If BPD is so similar to CPTSD, what remains? Now, I haven't addressed cognitive issues and affective issues. I'm looking at the time. It's almost 2:50, and I should obey the time. So I can talk about that in the question and answer period. And I know that there are kids, I've been tainted by decades of training, that are BPD in the emergency room, and I see the adults coming into the emergency room that have BPD. I need to shift my thinking to think more in terms of complex PTSD, I believe. But I'm interested in your thoughts. So again, I want to underline that I don't believe the impulsivity, irritability belongs to BPD. I think it belongs to a very treatable externalizing disorder, the ADHD, the oppositionality, the irritability, which we more and more are talking of severe mood disorder, disruptive mood dysregulation disorder, bipolarity. We don't need it. Let's just go back to bread and butter ADHD-I and treat it. And I could talk about weak boundaries at some point, but we don't have time for it today. And Lorraine, am I right that that's the end of the presentation, or do I have more time?
I actually have more time, Brian. Definitely, you have another five minutes for sure if you want to. We only got the one question that's been asked so far.
Okay, so I'll take a moment to talk about cognitions. And if I were raised by a family of adversity, I'd be bombarded by people who are mistreating me. And I have developing cognitions. I have affects that are intensely negative if I'm being subject to adversity, beaten or put down. What do I do with my affect, which is so strong and I have nowhere to put it? And in this context, often the youth that do go on to complex PTSD or BPD often don't have access to a healthy container and someone who will make sense of the journey for him. And if any of you have heard of Bion, you're familiar, he's very hard to read. He was an analyst from the UK decades ago, moved to Los Angeles and became the analyst of the training analysts. And he talked about the beta bits coming from the child, proprioceptive experiences of the child. I need to vomit, I'm hungry, I'm tired, I'm irritated. And when the child will come forth with sounds related to these proprioceptive experiences, the mother would take it in and create an alpha function and would make sense of the child's experience by saying, oh, sweetie, you're tired now, let's put you to sleep. Or, honey, you sound like you're hungry, let's give you something to eat. And if you do this all day, every day, for a couple of years, the child has a coherent and cogent experience of their universe, of their feelings, and those of others. It takes more than a couple of years, but it's a good start. If the child is bombarded with a lack of attunement, Linehan's notion of lack of attunement, which is characteristic of adversity, what is a child going to do with his proprioceptive experiences, his noises, his concerns, his complaints, and his experience of life? So the child has not a coherent understanding of his or her own internal experiences and is sabotaged in an experience of the outside world. And if you have all these chunks of self that are disconnected, you're at a real disadvantage for understanding relationships later on, understanding yourself, and understanding how you can integrate adversity from the outside and normal everyday experiences. And specifically with cognitions, and what else I would say with respect to that is, I think what these borderline children do, and I have trouble with the term now, these CPTSD children do, is their very best at making sense of their environment. So their character is formed of bits and pieces that are pasted together in ways that are not coherent and don't make a cogent narrative. And so in treatment, what we try to do is unglue these bits and pieces and try to stick them into a more organized fabric and lattice. So cognitively, I think that process of bits, of no alpha function, of no coherence, sabotages their efforts to make sense of the world. But I think they also need to not make sense of their experience, because I think it would be very overwhelming for these kids to understand that they did come from adversity and how poorly they were treated. And adversity is not a loving environment. Adversity is a non-loving environment. And I think it's overwhelming for the psyche of the person to consider that they have not been loved. And I think the cognitions are driven, the or the unusual cognitions are both an outcome of this non-coherent self, but are also protective so as not to see the experiences of adversity that they came from. As far as the affective instability is concerned, once again, if they have not had containers to help them deal with the adversity, so not only have they had adversity, but they have not had healing containers, and they have not therefore had anyone to help soothe them and to put the negative affect into perspective and to gently guide the negative affect into something that makes sense, a journey of healing. They're left with very raw, intense affects, which to me is also a product of the irritability. Because if they are not wired properly, if they are part of the ADHDI population without a strong connection between the prefrontal cortex and the limbic lobe, they're left with very raw affect, biologically difficult to neutralize and to integrate into a whole self. So for me, it's about adversity, it's about CPTSD, and the worst case scenario is adversity plus the irritability of ADHDI. When you put a child who biologically is programmed for ADHDI into an environment of adversity, it's like a double whammy. And so often it is the case because someone who's wired for irritability, a parent who's wired for irritability, would be very vulnerable to mistreat the kids. And I'm not saying that everyone with ADHDI is mistreating their kids. I'm just saying it's a breeding ground. It's a potential breeding ground. So what you end up is with adversity and as a breeding ground and ADHDI as a breeding ground, and the two of them making a stew that comes out as, from my perspective, either CPTSD and or ADHDI. I think I used up my 5 minutes, Lorraine. Am I right?
Yeah, you're up there, that's for sure. I have a question for you, however.
Sure.
One of the participants is asking, does this put in question the BPD diagnosis, in adults or adulthoods?
So I have been informed to behave myself and do not question, Brian, the adult data.
Well, there's the question for you though, but.
So I will therefore go out on a limb and I will say yes. If you have a chance to meet someone with BPD, an adult in a crisis setting, and you ask the right questions, you will be impressed with the degree of adversity that they had come from. As well, you will be finding a lot of people in the BPD population, adult, who have an undiagnosed ADHD, which for me is horrible, that they've gone through life with undiagnosed irritability, which is treatable, and they've been misdiagnosed with BPD when the irritability of ADHD could have been addressed a lot sooner. And in the old days, decades ago, when I started working with Gabby Luis and Lily Heckman in ADHD research, we used to say, just clean up the biological components of ADHD and leave the kid to heal himself interpersonally. He will find his way with other kids, that a lot of the difficulties of his attention deficit, his hyperactivity at the time, and maybe a little bit of the impulsivity would evaporate, and then he'll be able to find friends and get along interpersonally. So I'm supported by that information from the past, and also currently, I send these supposed BPD kids who meet criteria on the AB-DIB and the diagnostic interview borderline, meet criteria for BPD, and I treat them, the component of the impulsivity, properly as ADHD, and their problems interpersonally disappear. So do I think that there's stuff to extrapolate to the adult population? How big is the span of my hands? Hugely.
It's huge, yeah. Exactly. Well, that was the only question I had from participants. I was just curious about one element, however, when you were talking about cognitively and how that affects and how it affects some of these ways of dealing with the world when you're plagued with this kind of disability. What about the construct on attachment styles? It's something that's been talked a lot about, and how that can affect also. That's an important variable as to how you see the world and how you'll be able to socialize with the world. Would that not be an important component also to consider with the ADHD?
Wow, what a hard question, Lorraine. I should have spoken with you before the webinar and asked you not to ask me that question.
I'm sorry about that.
That's a great question. So attachment disorder, there are several ways of perceiving it, but one way I would understand attachment is that it's driven by something in the environment. Now, I haven't worked enough with attachment disorder, and I should really discuss this with the experts in attachment disorder. Mm-hmm. But my guess is to give the benefit of the doubt to the child, that the child is an innocent bystander in this process, and that if we can properly align the relationship with the parent and the child, that it will not be experienced as adversity. So I guess what I'm doing is I'm calling the environment that breeds the attachment disorder as somewhat akin to ACE. Okay. To the adversity. And so I'm now saying that since that's ACE, I'm seeing a bit the complex PTSD as reflective of an ACE. And that may be very unfair of me to do that, very unfair. But that's how I view it now. But I must say, I don't see a lot of attachment disorder amongst suicidal youth presenting to an emergency room. It happens from time to time. And when I see it, it's from an adoptive child. It's a child who maybe was adopted after several months or maybe several years in another country where there wasn't much control over parenting style. They were in an orphanage, maybe mistreated, again, the ACE.
Mm-hmm.
So then the question becomes, if they had ACE and CPTSD, if they were stuck with the primitive defenses of BPD, and they've learned to not relate or to mistrust or to keep a distance, I would call that protective. And that degree of BPD, how do you untangle it? Because I think there's a spectrum of ADHDI. So some kids are more irritable. Some kids are less irritable, less impulsive. So clinically, they would come across as just verbally impulsive. But some have temper tantrums, scream and shout, fight the police, the teachers, the parents. It's a spectrum of ADHDI. I think there's a spectrum of BPD where if the adversity is just over the threshold, it's a mild BPD. And if you wish, an extreme form would be what you're calling an attachment disorder, where the adversity was overwhelming and chronic for too long without any real healthy caretakers. And then they're stuck with primitive defenses and protective barriers after several years of the mistreatment. And so if you wish, I see the attachment disorder as a severe form of the CPTSD and BPD.
Okay, great. Well, thank you very, very much for your presentation and your answers. The time is up right now, and I would just like to remind everyone that all the presentations are being recorded, so they'll have access to this in a few months, or rather in a few weeks from now, on the websites of the three organizers, the CASP, AQPS, and CRISE. So again, thank you very much, Brian.
Thank you for having me. Good to meet with you all.
Bye for now.
Bye.